All right, welcome to the next installment of Live Well with UCI Health. I am Ryan Manno from KOST 103.5, the Ellen K Morning Show on iHeart Radio. I'm sitting here with three distinguished doctors. We will go down the line and have you guys introduce yourselves and what you do here at UCI Health.
Hey, thanks for having us on.
Yeah.
My name's Andy Lee. I'm one of the heart failure cardiologists at UC Irvine. Been here about 5 years. I also have a distinct interest in cardiometabolic health as well, and I'm very happy to be here.
Great.
Great. My name is Qing Yan. I'm one of the endocrinologists here at UCI Health, and I serve as the endocrine chief and also diabetes center director.
Okay.
It's a real pleasure to be with you today. My name is Nathan Wong. I'm a cardiovascular epidemiologist and a specialist in preventive cardiology and professor and director of the heart disease prevention program here at UCI and also co-director of our Center for Global Cardiometabolic Health and Nutrition.
Quite impressive, this resume. And look, we're going to get into something that I'm very excited about this topic. And I just want to start by saying, because we're going to talk about GLP-1s, medications like Ozempic, Wegovy, Mounjaro, Zepbound. I am a GLP-1 user, so I'm very intrigued by what we're going to dig into today. Specifically, I feel like in the last, year and a half, 2 years, these things have really just exploded. People are excited about them. I know that we're still learning about them. There's still a lot of questions, maybe some doubt. So we'll try and dig into all of this today. Dr. Yang, what are these medications and why is everyone so jazzed about this?
Right. So GLP-1 actually is a hormone, gut hormone. Everybody makes GLP-1. You and me, everybody sitting here, actually makes a little bit of GLP-1 right now even. However, after you eat, we make more GLP-1. The purpose for that is to help the pancreas to make a bit more insulin. That's a primary function. Now, the GLP-1 drugs are a bit different from the hormone we make.
Okay.
So it's a modified GLP-1. It's more powerful, more strong. And then cause significant weight loss. That's a benefit of this drug versus endogenous hormone.
Okay.
We're very excited about this because there's several reasons. One is, as I said, a very powerful medication for weight loss. The second has to do with tolerability, meaning most people can tolerate this drug as you are using right now, probably have experience. So not a lot of side effects, some side effects, not a lot.
Yeah. That's
why we're excited about it.
Mm-hmm. And it's also helping people. I mean, look, the weight loss thing is tremendous, right? I think that's probably why a lot of people are into it. But, there are other things that we will talk about. But specifically, it's helping a lot with managing diabetes. How does that work?
Right. So as I mentioned, the endogenous, the GLP-1 we make helps the pancreas to make more insulin, right?
Got it. So
that's one reason they lower sugars. But the drugs are so powerful because in addition to the pancreas, the drugs also work on the brain and the gut. So in the brain, these drugs suppresses the appetite. So you don't feel hungry.
Yeah.
In the gut, it slows down the movement. So the nutrient absorption will be slowed down. And altogether, it will be very powerful to cause weight loss and also improve diabetes.
How much weight, so if someone's watching this, listening to this, and they're on the fence about this, how much weight do you see on average a person typically losing? Or can they lose?
Right. So it's quite a variable, actually. So from the clinical trials, it's around 10 to 20%, depending on patient population, what kind of drugs the patients are using. In the real world, it's very variable. Some people can lose a lot of weight. From my patients, I see patients losing 100 pounds.
Yeah.
It happens. But some people just lose 10 pounds, 15 pounds. It's variable.
Do you find that the initial weight loss is greater than the sustained weight loss? Like, does it hit early and a lot right up front and then kind of slow down?
It's true, but we do what's called a dose escalation. So we start with a smaller dose, gradually increase the dose. So we usually reach the highest dose where you can tolerate.
Yes.
And you peak your weight loss, and we maintain that dose.
Yeah. Dr. Wong, what additional health benefits are you seeing with these GLP-1 medications?
So having been in the cardiovascular disease prevention field for some 40 years, I'm very excited about the ability of these drugs to improve cardiovascular outcomes. And so we've published several studies that involve Wegovy as well as Zepbound, and we've estimated that 93 million U.S. adults may be eligible for these therapies, and besides reducing obesity prevalence by up to 55 million in the United States, we found that we know that these therapies significantly reduce blood pressure by about 10 points, systolic blood pressure. They also improve both the good cholesterol, HDL cholesterol, by about 10%. They reduce the bad LDL cholesterol by about 10%. They also reduce triglycerides by about 30%. And because inflammation is also a major cause of cardiovascular disease, they reduce levels of an inflammatory measure called C-reactive protein by up to about 50%. And when you put all these risk factor changes together, we've estimated that one may see a reduction of about 18% in their risk of cardiovascular disease, such as on Wegovy, up to about 24% on Zepbound, potentially preventing between 1.5 million and 2 million cardiovascular events over a span of 10 years. So I'm very excited about these effects. We also know that there's some evidence that these drugs may even reduce risk of Alzheimer's disease and can be effective in treating sleep apnea. And we'll talk about later, but also prevention of diabetes, right? So individuals with overweight and obesity, one of their biggest risks, besides cardiovascular disease being their leading cause of death, is the development of diabetes. But we know that these therapies from one major clinical trial called SELECT, which involved Wegovy, reduced diabetes incidence by over 70%.
Wow, that is incredible. So Dr. Wong just touched on the cardiovascular thing. Dr. Lee, what about patients suffering from heart failure?
Yeah, like this is, I think, one of the most exciting parts about these GLP-1 family drugs. Just to expand on what Dr. Wong was talking about, you have these obesity-related conditions that could be potentially treated. And when you overlap like the treatment of both obesity and, say, for example, heart failure or sleep apnea, these obesity-related conditions, then these patients can get better. So in particular for congestive heart failure, this is a bit more of a nuanced conversation, but just to keep it simple,
Sure.
we now can kind of subdivide heart failure into those with normal heart function, those with weak heart function. And in this particular case, we're talking about patients with normal or preserved ejection fraction or heart function. So when you take these patients who have obesity-related heart failure with preserved ejection fraction, they have shown through these different medications with semaglutide, with tirzepatide, so either with Zepbound or with Wegovy, there's actually a benefit in terms of how these patients do in terms of symptoms, quality of life, ability to walk, and then actually reducing their heart failure hospitalizations. So we're really expanding these indication of these medications, and now cardiologists are, in fact, comfortable prescribing GLP-1s for a myriad of different reasons, right? And one of those can be heart failure with preserved ejection fraction. So more to come, you know?
Yeah.
I think we need more data to really know for sure exactly what we're treating there. There's various theories. Some of these theories do involve like visceral adiposity. So in patients with obesity metabolic syndrome, like they may actually have fat cells building up around the visceral organs, such as the heart. And by reducing that visceral adiposity, it's thought that it may help with heart function.
That's incredible.
more to come. We still have a lot to learn, but it's extremely exciting.
Yeah. Now, I know snoring at night is different than sleep apnea, but you guys have mentioned snoring. I have found, so I track my sleep with this app, okay? I have noticed in the last year that I've been on these, my snoring, is that a thing? Am I making this up? I mean, my snoring has gone from like an hour and a half or 2 hours a night to like 2 minutes. Wow. Is that part of this?
Yeah, it's FDA approved Zepbound for the sleep apnea.
Yeah.
So,
and I'm sorry, I'm taking us off course, but how similar is snoring to sleep apnea? Are they in the same family of behaviors? No.
No.
Okay.
So snoring is just a snore, right?
Right.
But
why is my
apnea,
snoring going down on GLP-1s?
Well, sleep
Maybe
apnea,
I've lost weight. Is that why?
There's thought that
okay.
sleep apnea snoring can be due to neck circumference, right?
Yes.
And if that's
apnea.
potentially modifiable,
Yes.
right, that may help.
Okay. I love it.
Yeah, sleep apnea, you have to have stop breathing for a period of time.
Yeah,
on
right.
top of the snoring.
Okay. See, I have a bunch of my own personal questions. I'm just trying to keep us on track here.
right.
Okay.
Great.
Dr. Lee, back to you. So you are involved in clinical trials, right? For various things. What specifically are you involved in? I don't know, now, or what's an exciting one that you can talk about?
Oh yeah. So both me and Dr. Nathan Wong are involved with the tirzepatide trial for cardiovascular outcomes here at UCI. We're one of the sites in this international study, and I'm the site primary investigator. So the name for this trial is Surmount MMO, but it's extremely exciting to be a part of this trial because then, we were able to start with tirzepatide when it was still, sort of up and coming, just had gotten approved by FDA. They had ongoing trials with diabetes, with those results released at the time of enrollment when we were starting up. Now we're about 3 years into it. So we've recruited some patients. We've kind of followed them out. We've been able to see, some, I'd say, isolated patient benefits, and from there, contributing to the science and seeing overall, how does this medication actually benefit cardiovascular patients? Like in this case, we're not really treating obesity. We're treating patients with either a high risk for having heart disease, or they already have existing heart disease, or some other cardiovascular disease, such as stroke or something like that. So really, this is going to sort of expand the label indication of this medicine, right? Because right now this is approved for diabetes, it's approved for sleep apnea and for weight loss. It's not yet approved for reducing cardiovascular risk.
But you want to get there.
We're contributing to that science.
Yeah, I love that.
And I might also add that so the Surmount MMO trial that Dr. Lee has mentioned, this is going to be very important in particular because unlike the earlier SELECT trial that involved Wegovy, Surmount MMO is also including people without pre-existing cardiovascular disease but have overweight and obesity. So it's going to really answer the important question, right, of whether or not these therapies can improve cardiovascular outcomes in, a much larger proportion of patients who don't have pre-existing cardiovascular disease.
Yeah, that's awesome. Dr. Yang, let's, I think that one of the concerns for anyone would be side effects. And that's true of any medication, right? You watch TV and the list of side effects is longer than the commercial, or possible side effects. What can we expect in terms of side effects from these medications?
Right. So overall, as I mentioned, they are reasonably tolerable.
Yes.
It's probably from your experience too. Now, there are two major side effects I want to mention. The first one, of course, is GI, the stomach.
Okay.
So it slows down the stomach. You feel full, bloated, constipation. Some people have diarrhea, occasional vomiting. It happens. So to attack that, that's why we do the dose escalation from a smaller dose, let your stomach get used to that, and then we use a higher dose to achieve the therapeutic effects. The second I want to suggest is to easily digest food. If you eat greasy food, the digestion slows down from beginning. The medication add to that, then you would have more stomach side effects.
Right.
So these are two things we do to help with GI side effects. Now, second major side effect is quite interesting. It's called lean or muscle mass loss. So it's a big one. It's an active research interest for a lot of people. So say you use a medication, you lose 10 pounds, right? And among those 10 pounds, 7 pounds are fat mass.
Okay.
And 3 pounds will be your muscle mass. And you don't want that, right? So if you lose a lot of muscle mass, you would feel weaker and fatigued. So we encourage people to take some protein,
Yes.
occasional protein powder, and also encourage them to exercise. Very important to keep the muscle mass.
Sure.
Otherwise, you'll feel weaker.
Yeah.
Now, there are some side effects are less common, but we usually consult the patients like pancreatitis, gallbladder issues. We usually screen them before starting the medications. We don't use them if they have pre-existing conditions. But even without those conditions, we need to watch those carefully.
There was one that I, just from another personal, aspect, when I started, I did notice like some nausea the first couple injections.
Yeah.
I think they gave me Zofran too for it, and it took it right away. So, and that didn't last long. You hear about that and you're like, oh God, am I going to walk around life nauseous? No, it goes, you're getting used to it, I think.
Exactly.
Right? Yeah.
Exactly.
I might also
Please add.
Perhaps add that, to Dr. Yang's comments, regarding the potential loss of lean muscle mass, that, we really encourage patients, in addition to general exercise, but in particular strength training.
Sure.
So perhaps, doing a little bit of weights would be worthwhile. And one very interesting side effect, maybe it's a good thing, that was recently reported was perhaps less of a desire for alcohol use. So maybe it's potentially reducing people's intake of alcohol.
Like the desire or the ability?
Perhaps both.
Okay.
Yeah.
Got it. Interesting. This is a totally off the page one again. And tell me I'm crazy. I feel like, because I did stop them for a little bit, and I feel like it helped my mood. And that could be the result of feeling better about how you look. Are there potential that you guys have seen? Is there any potential for this to be like a mood booster or stabilizer?
Right. So I always tell my patients, so if you lose 30 pounds,
Yes.
right? Before your weight loss, you are carrying a 30-pound bag walking every second.
Yeah.
You are fatigued, you are frustrated.
Yes.
After the weight loss, you feel lighter and
Yes.
more energy, even though you may lose some muscle mass. If you exercise, you can keep that, but you feel better. A lot of people feel better. Having said that, there's some early studies showing that some people may feel worse psychologically because you take away the joy of the food.
Oh.
Some people are foodie,
I love food, but I'd rather look at
Right,
honestly.
right.
Just I don't
Exactly.
care. Fit in my
So-
clothes. I don't get. Yeah, I'm good.
Exactly.
Yeah.
So, but overall, most people feel better.
Yeah. Okay. I love that. There's obviously the next question. I remember when I would get on this and discuss with my friends and family, they're like, "How long are you going to take this? Like, what's the plan for that?" So, how long can people, stay on these GLP-1s?
That's a big unknown, right?
Did I unlock something big?
Well, I think this is a point of contention, right?
Sure.
Like, how long are people really going to stay on this for? Like, if it's just for weight loss, like for whether it's like health or cosmetic reasons, then sure, you can take it as long as you want to. And it's been shown to be safe, in terms of the long-term data that is available. But as soon as someone stops the medicine, then they put the weight back on, right? So then this is sort of like the catch-22 in terms of how long are you really going to be on it for? And then now we're expanding these indications, right? For sleep apnea, for cardiovascular prevention, for Alzheimer's prevention. Is this really going to become a lifelong drug? I think it's reasonable to think about that. I do think the indication is going to kind of modify that decision on the personal level as well, right? If this is entirely if someone's having like overweight, obesity as a consequence of bad habits, whether it's like dietary choices or not enough exercise, then I always tell my patients, habits take years to develop, right? Like, someone might have been conditioning themselves with this kind of, say, poor dietary choices for decades, and then we're all of a sudden asking them, to change their diet in clinic, and it doesn't happen. But now we have this medication that at least can kind of take off that at that subconscious level, at least affect their dietary choices, right? And then they see the benefits. They might be more motivated to form better habits. I think that is something that could be worked on in the future, right? We shouldn't just say, hey, this is the miracle medicine, you got to keep taking it. But there is going to be that component of dietary lifestyle counseling as well, which is equally important. And as you know, now that we have an effective treatment, that is going to be a greater emphasis, right? People are going to be coming and seeing us more to talk about this stuff. So that's kind of how I view it. You know, it certainly depends on the indication, depends on the patient's motivations as well. It's safe long-term, and then, you know, we'll see what the future holds.
What happens when patients stop taking it?
Well, they put the weight back on. If this medicine really does kind of cut cravings for alcohol, maybe they will start, feeling those cravings again. Who knows, right? In terms of preventing diabetes or controlling diabetes, if that's the indication, then the diabetes control may get worse, right? For heart failure with preserved ejection fraction, like there may be lots of different components at play there, whether it's preserving, say, kidney health or preserving just like their cardiometabolic syndrome. Like we don't want that to get worse, right?
Yeah.
And their improvements in their cardiovascular risk factors will be reversed. So, their cholesterol's going to go up, their triglycerides, their actually blood pressure. So, patients really need to understand that these drugs could potentially be a long-term commitment, particularly if they're not modifying their lifestyle. I completely agree with Dr. Lee that, one thing about these, therapies, right? They are always considered an adjunct to a healthy lifestyle, diet and exercise. So it's crucial that following a heart healthy lifestyle, such as a Mediterranean or DASH type diet with regular physical activity, that's still the foundation. And patients need to understand that, and our healthcare systems need to support that by making available registered dietitian nutritionists that can help patients with their journey and using these therapies together with a heart healthy lifestyle. So that cannot be overemphasized.
Yeah. Just another personal level, what I thought, so I took a break from them, and I made the mistake of thinking, okay, so I've modified my lifestyle, I've changed my food consumption, I'm kind of where I want to be. Let me back down, get off of them, and hopefully these new habits have stuck, and these new behaviors are just going to be part of my new normal and take hold. That lasted all of a week, and then I'm like, oh my God, here it is. I'm craving food again. I mean, it actually shows you the efficacy of these, because you can see it and feel it in real time. You're like, crap, these cravings are back. It happened, and I saw it and I felt it. So it really, I think, to all of your points about, it's almost like that reverting back to where you were when you started. It's a real thing. Let's talk about, the coverage and the cost of these. I know that some plans will only cover them for certain conditions. And even then, copays can range from somewhere like $500 to $1,000. Why are they so expensive?
Right. So, as I mentioned, the GLP-1 is a hormone, actually. It was discovered in the 1980s. It took a long time to develop GLP-1 drugs. The first one was approved, I think, in early 2000s, when very effective. Ozempic was 2017. So during that 3 decades, there are a lot of patents, a lot of research, a lot of money invested. So that's one reason. All new drugs are expensive. These typical GLP-1 drugs are quite expensive. Now, I'm hopeful. There are a lot of drug companies right now are developing the kind of next generation GLP-1s. Longer time, more effective. I'm hopeful in the near future, these newer drugs coming out, and the older drugs will be a bit cheaper. Right now, they are quite expensive. Of course, big pharmas make money from these
Of course.
medications too. So
Yeah.
as you know, Lilly is the biggest pharmaceutical company right now because of these drugs.
Is it one of those things where the popularity is there, the demand is there, so you can charge more? Is that it? Kind of.
Well, just the volume. There's just so
volume.
many people are using it.
Okay.
And some drugs, very few people use it, but these drugs, just so popular right now.
And I know that people are turning to compounding at pharmacies and things like that to try to find it cheaper. No, you're shaking your head. No, not. You don't.
No,
what do you tell your patients?
I don't like that.
You don't. Why?
Idea. Well,
Why?
The problem is that these are not regulated by the FDA.
Sure.
So we don't quite know so the patient doesn't quite know what they're getting, right? They're compounded with other therapies, and there have been reports of adverse effects on some of these compounded therapies. So we always recommend sticking with the FDA-approved branded therapies.
Got it. Why aren't they regulated? And pardon my ignorance on that, but where's the lack of regulation on this?
So those compound medications are made by pharmacies.
Yes.
Those pharmacies are not federal government regulated.
Okay.
Those are mostly state regulated, controlled, and there are no specific kind of laws or governing that regulation either. So not only GLP-1, there are many other type of medications or compounded medications. As I agree with Dr. Wong, try to avoid that. But having said that, there are some nuance here about the cost because it's not covered. So I think I'm really hopeful, as I mentioned, in the near future, these medications would be cheaper and more affordable.
Good. I hope so too.
Yeah.
Back at the start of the year in January, I know Medicare and Medicaid stopped covering them for weight loss. Maybe you guys can tackle that. How does that then affect your patients and what you're telling them or what they're able to do?
I think Medicare didn't cover the weight loss component.
Got it.
Medicaid, California, Medi-Cal did.
Got it.
But from January, that part will be removed, meaning the insurance, Medicare and Medicaid will cover obesity with comorbidities, meaning diabetes or cardiovascular disease type of things. So that would affect a lot of people who are on or plan to be on the treatment. So, it's challenging to manage those patients.
Yeah.
And we're concerned that, these therapies not being as available to our Medicaid patients.
Of course.
This is going to result in increased health disparities with respect to obesity and the other benefits that these therapies have. So it's a major concern among our underserved populations that have an excess of obesity, diabetes, and cardiovascular disease.
Is there a point, though, where you will be able to prove that these folks do need this, right? And so that they are covered? I mean, maybe I'm not maybe I don't have a full, scope of understanding on it, but if someone actually requires this in terms of public health, right? The general larger public, if you can point to this and say, these folks need this, this is improving their quality of life, it's improving public health, how can they say no?
It's a very good question. So again, insurance companies, they have their clinical policies,
Yeah,
right?
but you're the expert. You're saying, hey, this person needs this.
Absolutely. So,
Yeah.
so usually what we do is we go through the called a PA process, pre-authorization, to justify why the patients need the treatment. For example, just simple example, sleep apnea is approved by FDA, but not a lot of insurance companies that don't approve that indication. So it's just that's a reason a lot of patients are not benefiting these revolutionary drugs. It's very unfortunate.
Yeah.
Yeah.
Dr. Wong, what studies do you guys have going on right now that are new that maybe we haven't touched on?
Yeah, so this continues to be an active area of our work at UC Irvine. So one study is we're looking at a national electronic health record database and trying to understand what are the social determinants of health as well as quality of life issues that may affect patients' long-term adherence and their success on these therapies, particularly with respect to diabetes control. But, we're also going to look to see how, their success with controlling obesity might be affected by these factors. So that's one ongoing study. We're also planning to, getting back to the pre-diabetes issue, because I think this is one of the underappreciated benefits of these therapies is their potential effect on reducing diabetes incidence, which, as I said, was already shown by the SELECT trial, more than a 70% reduction. So we're trying to investigate because, of course, that clinical trials are oftentimes done in very select, highly motivated populations. But what might the effects be in real-world populations?
Sure.
So we're planning a study that's going to look at that, and we also continue to be interested in looking at how does the use and maybe also the benefits of these therapies, how might it differ across different race and ethnic groups. There's a important Hispanic diabetes initiative that Dr. Yang and others and myself are involved with which here at UC Irvine, which is very interested to see, how we can better improve care among the Hispanic population, which is, a very major part of the Orange County population. And so how can we improve diabetes care, not just through use of these newer therapies, but what's very important also are other factors that affect outcomes in people with diabetes, right? Such as better blood pressure control and lipid control. So for a number of years, we've done work in this area looking at how composite control of multiple factors can really improve outcomes in people with diabetes, such as we've shown that control of LDL cholesterol, blood pressure, and A1C together can reduce cardiovascular events by about 60%. So this is a very active area of our work, and Dr. Yang, Dr. Lee, and I, are also part of the new Center for Global Cardiometabolic Health and Nutrition, which is doing collaborative research across different schools within the university, such as the School of Pharmacy, Nursing, Information and Computer Sciences, as well as medicine and public health, and trying to see how we can improve outcomes, particularly in our underserved patients with obesity and diabetes.
Yeah. Well, I mean, listening to you guys talk, I mean, clearly you're knowledgeable, and it's got to be exciting for you guys to be, exploring something and what's next with this thing that is so, I don't want to say hot right now, because I mean it's a medication, but it's so in the public psyche right now. So it's thrilling that you guys are kind of like leading that charge. Specifically, UCI Health, Dr. Yang, what options or what treatment, things does UCI Health offer people with diabetes or looking for weight loss that maybe other providers can't?
Well, UCI Health is the only academic medical center in Orange County.
Yeah.
And we also have a diabetes center, which is the only research institute in the county. So we use these medications, but we are also doing a couple of clinical trials, testing the newer GLP-1 drugs. Some of them are oral. You don't have to go through injections.
Are they as effective?
So based on the preliminary data, they're quite effective. Maybe not as effective as the strongest drug injections, but fairly effective. So there are, we are uniquely positioned in different areas other providers cannot provide: research, clinical trials, and our faculty members are outstanding. And we actually, the endocrine division ranked number 50 among the 4,500 hospitals in the country.
Oh my
In
God.
2023, yeah.
Take a bow. That's awesome.
Thank you.
That's great.
Yeah.
Anything else that you guys, feel passionate about getting out there? Any messaging that maybe we missed that you want someone to really know and take away before they either start these or, continue or stop them? I mean, anything else? Do we cover it all?
I'll just add, and this again reemphasize that patients need to understand that these drugs do far more than promote weight loss,
Sure.
right? And in our overweight and in our patients who have overweight and obesity, cardiovascular disease is their leading cause of death, right? So this includes heart failure, this includes heart attacks, and atherosclerotic CVD in general, which also includes stroke, right? These are going to be their major causes of death. So it's very important that they understand the cardiovascular benefits, and our cardiology community really needs to embrace these as therapies that are not just for weight loss and not only for diabetes, which is of course very important, but as cardiovascular therapies. And I think certainly, with all the emergent data with heart failure that Dr. Lee talked about, they will hopefully soon be. But I think that's the number one message that I have for patients, that they're much more than weight loss drugs.
Yeah.
And just to expand on that too, there's this new concept in our field called cardio-kidney metabolic. So expanding not just from the, cardiac side of things, as Dr. Wong has been talking about, but also, renal health. Like with diabetes comes attention to kidney function and preventing the development of diabetic kidney disease. And these medicines have demonstrated some renal benefits as well, So cardio-kidney metabolic, these ailments affect a large size of our population, right? So in terms of this program today, just drawing to attention these health benefits that this family of medications can offer is huge. And really, it's not just about weight loss, but seeking out medical providers just to talk about if these type of medicines are right for them.
Yeah.
I think that's a huge advantage in terms of talking about future health as well, right?
Yeah.
That reminds me another strength of UCI Health, which is an interdisciplinary approach to manage these patients.
Mm-hmm.
So Dr. Lee, I, endocrinology, kidney doctors, we all work together. We are same medical record system. We communicate all the time. So that's the strength of our system.
Fascinating stuff. I know we're talking about GLP-1s, but I'm going to call you guys the GLP-3. This is it right here. Yeah. Thank you guys so
Thank
much
you very much.
For your time and your expertise. And I know this is going to be beneficial for a lot of folks to hear for a lot of different reasons too. It's a really exciting thing, and I'm excited that we had your time today. So thank you guys.
Thank you.
Thank you.
We'll catch you next time. It's Live Well with UCI Health.